the webinar. So I hope you find it interesting and enjoyable and educational at the same time. Okay, so let's get started. Okay, so we as a nation have expanding waistlines, and a survey published in 2012 has reported that about a quarter of all adults are now classified as obese, and the sort of increase in people being overweight is on the increase as well. You can imagine that the health consequences attributed to either being overweight or obese are quite large, and it actually costs the NHS around $5 billion a year. So when we're sort of talking about obesity, we generally kind of use the BMI as a measure of sort of measuring obesity. But research published in the early 80s showed that actually the waist to hip ratio is more strongly correlated to metabolic complications than BMI itself. And accumulative evidence now supports the hypothesis that fat distribution as an important factor to consider when we're linking obesity to related health problems such as metabolic disorder, and type 2 diabetes. And it's now accepted that it's the presence of visceral fat, so this is the fat that surrounds the intestines and the vital organs, our sort of beer bellies, is a prominent risk factor for the development of insulin resistance because it harbors a pro-inflammatory environment that is the root of insulin resistance, which then leads to the development of metabolic syndrome and diabetes. Okay, so why are we getting bigger? Well, simple answer is that we're moving less and eating more. It's quite simple. In regards to the actual foods that we are consuming, well, many of the high carbohydrate foods that are really common in our Western diet actually produce an unfavorable glycemic response. And I guess if we sort of think about it very simply, we're just overloading our bodies with simple carbohydrate, which is increasing obesity, which in turn then increases the risk of insulin resistance, metabolic syndrome, and type 2 diabetes. Sadly, we are now raising a generation of children who accept that the sort of junk food, fast food culture is the norm. And unsurprisingly, the impact of such diets is actually being reflected in the increasing childhood obesity figures as well. In fact, children who eat poor diets are particularly vulnerable because it's the early life behaviors that actually track into adulthood and influence weight status later in life. And around 70% of obese children or adolescents will go on to become obese adults. So reducing the risk of developing obesity is without question highly important for reducing the risk of developing the health issues attributed to it, and this goes to say that this is for sort of any age group. However, if we can prevent the cascade of events that contribute to the development of insulin resistance, we could, in theory, prevent many of the health issues that are related to obesity-induced insulin resistance. Okay, so let's have a quick look at some of the sort of health risks that are associated with obesity. I'll sort of go through it fairly briefly. We know that obesity is linked to insulin resistance, which is then linked to metabolic syndrome, which is linked to diabetes. But having a raised BMI also increases blood pressure, which, if this goes untreated, increases the risk of hypertension, which is itself a risk for coronary heart disease and stroke, which can then go on to contribute to other conditions such as renal failure. There's also a greater risk of developing high cholesterol, high triglycerides, both of which contribute to the risk of developing atherosclerosis. We also see accumulation of fat in the liver, which can lead to non-alcoholic fatty liver disease. And the pro-inflammatory environment attributed to obesity can actually increase the risk of certain cancers, primarily sort of breast cancer and colorectal cancer. So there's sort of a myriad of health risks that are attributed purely to sort of being obese and developing insulin resistance. Okay, so We think of adipose tissue as this sort of essential reservoir for energy storage and energy release. But it's now widely recognized that adipose tissue is an active endocrine organ in its own right. And it's a host to a myriad of immune cells, so B cells, T cells, macrophage, and so on, that alongside the adipocytes themselves regulate numerous body processes, so immunity, inflammation, tumor growth, and so on. The state of obesity, it seems, has the ability to influence both the quantity and the nature of these immune cell subtypes, and this has the potential then to create a pro-inflammatory environment. So over the last couple of decades, considerable effort has been made to try to unravel the processes that occur within adipose tissue that are responsible for driving obesity-related comorbidities. And it's now well established that this driver is inflammation that arises within the adipose tissue itself. This metabolically triggered inflammation can be best described as the long-term inflammatory response that is triggered by a combination of both nutrients and calorie surplus. So the pathways and the molecules that are involved are similar to those that are involved in the classic inflammatory response, but act as both inflammatory mediators and regulators of both energy storage and metabolism. So they differ quite significantly, but they're similar at the same time. Significantly, however, it is the inflammatory products that are derived from visceral adipose tissue that directly interfere with insulin signaling pathways that then lead to insulin resistance. So it goes without saying that there is a clear association between inflammation and the development of insulin resistance. And this opens the doors to interventions that target inflammation and therefore have the potential to improve both insulin signaling and sensitivity. Okay, so if we look at our adipose tissue environment, well, it has the capacity to either be pro or anti-inflammatory. Okay, so how exactly does obesity trigger the cascade of events that actually lead to insulin resistance itself? Okay, so we have the sort of calorie overload. And as the adipose tissue expands, as we sort of build up sort of triglycerides within the adipose tissue, we see an increase in both the size and the number of the adipocyte cells. And this begins to exceed the capacity for oxygen supply. So there isn't a sort of a network there that is capable of sort of supplying enough oxygen. This leads in the long term to hypoxia, which then leads to cellular stress, and this then leads to inflammation. And this inflammatory response then releases a number of pro-inflammatory cytokines and other pro-inflammatory signals that then act to draw macrophage to the site. So the purpose of the macrophage is to sort of engulf all the sort of dead and dying adipocytes that are occurring within the sort of adipose tissue itself. Visceral adipose tissue is characterized by enhanced macrophage infiltration, which are themselves the prominent source of pro-inflammatory cytokines that are known to block insulin action. So we get overload, increase in size, increase in numbers, not enough blood supply, not enough oxygen. We get cellular stress, we get inflammation. We draw our macrophage in. Our macrophage start producing lots of pro-inflammatory products, and we can start to see how this sort of cascade of events starts to really sort of drive the whole inflammatory processes. Okay, so in obesity, there is a switch from macrophage, which have a sort of housekeeping phenotype, to a much more pro-inflammatory phenotype, and they're called M1 macrophage. The levels of pro-inflammatory products that are derived from these M1 macrophage directly correlate with both the degree of glucose intolerance and insulin resistance. Okay, so if we just sort of look at a couple of examples, for example, so macrophage produce TNF alpha, interleukin 6. TNF alpha interferes with glucose uptake by inhibiting phosphorylation of the insulin receptor. Interleukin 6 reduces lipoprotein lipase activity, and this results in increased concentrations of circulating free fatty acids and goes on to increase the risk of insulin resistance. Okay, so we've got this sort of nice cascade sort of concept growing in our heads. And here's a nice little visual. So we've got our nice little lean, slim amount of sort of fatty adipose tissue. And as you can see, there's a nice anti-inflammatory profile. We've got normal metabolic function, normal vascularization. We've got our M2 macrophage, so there's a lot of housekeeping going on. When we get dysregulation, we get a more pro-inflammatory profile, metabolic dysfunction, hypoxia, adipose necrosis, and there's this sort of cascade of events that are sort of driven by this M1 macrophage within the site. Okay, so we're talking about inflammation in quite a negative way, but I think it's really important as well to just emphasize that the inflammatory response is completely necessary. It's the body's natural healing process. And without inflammation, we wouldn't be able to combat infection. We wouldn't be able to dispose of dead or dying tissues. And we wouldn't be able to initiate any kind of sort of healing process. So it's not inflammation that's actually the issue, therefore. It's the resolution of the inflammatory processes and that is significant, because if we don't produce adequate levels of pro-resolving mediators, so these are the compounds that actually go, hey, crisis is over, it's time to sort of calm everything down now, we actually increase the risk of developing what's called low-grade silent inflammation. And so we can start to begin to see a relationship here between omega-3 fatty acids and dysregulated inflammation, because it's omega-3 fats and EPA specifically that are the precursors to the pro-resolving mediators that are required to draw the inflammatory process to a close. So therefore, omega-3 deficiency plays a significant role in dysregulated inflammation. Okay, so we get our inflammation within the visceral tissue, so we get visceral obesity, and this then drives our insulin resistance. And then we've kind of got our sort of link through to metabolic syndrome, and we've also got our sort of high triglycerides, low high cholesterol, hypertension, all these kind of things that are sort of contributing to metabolic syndrome, but are all, again, they're sort of linked through to insulin resistance. So, under normal circumstances, insulin binds to the insulin receptor, and this triggers a cascade of events that influence a number of pathways. But sort of keeping it short today, it's sort of the main one that we're sort of really interested in is that the binding of insulin to the insulin receptors pushes the translocation of glucose vesicles to the cell membrane, and this is what allows the movement of glucose into the cell. Insulin resistance is therefore just a physiological condition in which cells fail to respond to the normal action, of insulin through impaired insulin signaling. And this impaired insulin signaling, as we've sort of mentioned, is through a number of pro-inflammatory products. Part of the issue is that insulin resistance can be non-symptomatic for many years. So people can be insulin resistant and really not know anything about it, and it causes huge, huge issues. So if we can sort of identify people who are at risk, then we can start to see how we can kind of put this into practice. Okay, so we've got a nice little sort of summary. Okay, I'm getting some questions coming up, but I'll answer those at the end of the webinar if that's okay. Right. Okay. So Sorry, I lost my thread there. Okay, so this is just a nice little diagram which kind of is a summary of what I've been talking about. So we get our calorie excess, we get our adipocyte expansion, hypoxia, stress, inflammation, and so on. But I'll let you have a look at this a little bit later in your own time. So I've covered just about everything here, but it's just a nice sort of like diagram to sort of summarize. Okay, so there is good news. With weight loss, we actually see a reduction in the number of pro-inflammatory mediators, including pro-inflammatory TNF alpha, interleukin 6, for example. And we know that these are two pro-inflammatory products that play key roles in inducing insulin resistance. We also see a reduction in monocyte chemoattractant protein, which is one of the key products that drives or draws monocytes into the adipose tissue itself. And we therefore see a reduction in both, so we see a reduction in chemoattractive proteins, which then will correspond to a decrease in sort of macrophage being drawn into the adipose tissue. And not too surprisingly, what we actually see is improvement in insulin function and a reduction in inflammation. So weight loss itself is really important when we're sort of looking at obesity and the sort of link between obesity and inflammation, for example. And not surprisingly, most of the current recommendations from public health bodies for reducing body fat focus on increasing physical activity and eating a healthy and balanced diet. And so reductions in body weight, either through things like sort of calorie restrictions, and there's an awful lot of diets out there, or through more invasive techniques, so sort of liposuction and sort of that kind of thing, correlate with significant reductions in inflammatory markers and improved insulin sensitivity. Quite often, methods used to induce weight loss represent a quick fix solution rather than the lifelong lifestyle changes that are required to maintain a healthy body weight long term. And it's not surprising, therefore, and there's a sort of small meta-analysis here, it's not surprising that many individuals who lose weight will then go on to regain this weight, and sometimes sometimes it's not uncommon for people to put on even more weight than they had before they started the diet or weight loss strategy. So we need to have a look at sort of what else is out there to sort of help with these kind of things. And we've touched very quickly on the role of omega-3 as inflammatory mediators, but there's also quite compelling evidence that increasing omega-3 intake can promote weight loss. And omega-3s do this by discouraging the storage of triglycerides within adipose tissue through increased beta oxidation of fatty acids and an increase in thermogenesis. And I speak to lots of people who are sort of, tend to avoid taking fish oils or omega-3s if they're on a diet because it's fat and I'm trying to lose weight, and there's huge sort of, you have to really kind of explain that actually fish oils, they sort of drive weight loss rather than sort of put weight on. Anyway, back to it. So in fact, individuals who include fish or fish oils as part of a calorie-controlled diet will generally lose more weight than individuals who are on a calorie-controlled diet but don't include fish or fish oils within that diet. Okay, so not only are omega-3s beneficial in sort of weight loss, but weight loss diets that include oily fish or fish oils also see improvements in lipid profiles as well, because we know that omega-3, EPA especially, lower both cholesterol and triglycerides, which is quite important because they themselves are associated with metabolic disorders such as metabolic syndrome and diabetes. So it's a good all-rounder, really. Right, okay, so one thing that's quite important is when we're looking at sort of taking fish oils, do we take fish oils? Do we increase our fish consumption? Do we eat oily fish? Do we eat white fish? And there is a big difference. And what we do find is that sort of if you look at different studies, you'll get different results. And some studies will say no, consuming fish that has no benefits for weight loss or anything like that, and inflammatory markers. But so this is just kind of like a little example of a study that I found. Just point out that the use of the control was a bit of a poor choice, given that sunflower is absolutely rife in omega-6, which are known to be inflammatory, but we'll ignore that for now. The whole kind of sort of pointing out was that these individuals were assigned to 4 energy-restricted diets, so the 30% relative to what they needed. And they were asked to eat 3 portions of fish a week. So it was either 3 portions of salmon or 3 portions of cod fish oil capsules. So you can see immediately that 3 portions of salmon gives you an awful lot more omega-3, 2.1 grams, compared to your cod, which is 0.3 grams. And this is because oily fish keep their omega-3s in their flesh, whereas cod pops it into the liver, which is usually thrown away during the gutting process and so on. Anyway, so the sort of outcome of this study really was that whilst all of the 3 interventions, not the control, lost weight. Oh, sorry, no, the control lost weight as well because they were on a sort of calorie restriction. But unlike the control, they all had sort of favourable benefits on lowering inflammatory markers, but it was actually the salmon that significantly decreased 3 of the 4 sort of measures of inflammation that they used. So they looked at CRP, interleukin 6, and some other bits and bobs. But basically, so yes, so choice of fish is quite important as well. So oily fish. And then we have to sort of consider the fact that, you know, we're now sort of polluting our seas, and we're sort of advised don't eat too much fish. So we generally say to people, you need to incorporate fish and take fish oils as well. Part of the reason that fish is so beneficial is because it's obviously it's a sort of nutrition package in itself. So it's rich in antioxidants and proteins, good quality proteins that are all sort of participating in sort of reducing inflammation. So a couple of portions of oily fish a week, and top up with some EPA for the best sort of impact on inflammation. Anyway, too long on that slide. So okay, so let's have a look at the relationship between the omega-3 index and obesity. Okay, so we know that long-chain omega-3 fats have been shown to increase fat loss and counteract adiposity in both animal models and human studies. Okay, but if we look at biomarkers of fatty acid intake, okay, so we look at things like omega-3 puffers, they're not only associated with a healthier body mass index, but also with a waist to hip ratio. And as I've said previously, waist to hip ratio actually provides more accurate information on visceral fat accumulation than the BMI. So the omega-3 index, and this is actually defined as the amount of EPA and DHA expressed as a weight percentage of the total fat within cell membranes. And the omega-3 index provides really useful information on long-term dietary intake of omega-3. So we usually use red blood cell membranes because they provide a useful biomarker, and they actually reflect the omega-3 content within tissue itself, including adipose tissue. Okay, and if we look at the relationship between omega-3 index and BMI, individuals with higher BMIs tend to have lower omega-3 index and vice versa. Okay, and this is true for both adults and children. So we're beginning to see a nice relationship between omega-3 and obesity, omega-3 and inflammation. And given that there is a relationship between obesity and inflammation, we can start sort of thinking about the question, is there room for clinical application using omega-3? So, talking about, yes, have your 2 portions of fish a week, but what are the added benefits of increasing your omega-3 using purified EPA supplements? Okay, so have a little bit of clarity here. Nice little diagram. So we've got our omega-6 and we've got our omega-3 fatty acid pathways. And as you can see, they share the same enzymes that are required to convert short-chain parent fats, so these are the fats at the top, LA, ALA, into the long-chain sort of physiologically active fats. So I've highlighted AA and EPA. And I've highlighted AA and EPA because these are the 2 long-chain fatty acids that are actually responsible for regulating inflammation. So AA is the precursor to pro-inflammatory products, and EPA is the precursor to anti-inflammatory products. Individuals with obesity, metabolic syndrome, and type 2 diabetes have all been shown to have different fatty acid compositions compared to healthy, lean subjects. And this is in part because insulin regulates desaturase activity, and this is in particular it's delta 5 desaturase that is really sort of impacted on. And this impairs long-chain fatty acid metabolism, and particularly it impairs the conversion of ETA to EPA. It does impact on DGLA to AA, but because we have such a high intake of omega-6 fatty acids, delta 5 desaturase, what's left of it tends to sort of hog down this way. So we kind of produce enough AA, but it's our EPA and therefore our DHA that's sort of really impacted on. Okay, and what we find is that individuals with insulin resistance generally have much lower levels of EPA and a much higher ratio of AA to EPA than on healthy non-insulin resistant individuals. Okay, so because AA is the precursor to pro-inflammatory and EPA the major precursor to anti-inflammatory end products, we can begin to see just how insulin resistance can drive inflammatory processes. Okay, so this is just a slide really that's summarized actually what I've just said about desaturase activity. Right, okay, so this is a nice slide that kind of really is a good visual to highlight the importance of the AA to EPA ratio in the process of the inflammatory sort of resolution. So at the beginning of an inflammatory response, we get, during the initiation part, we get the release of pro-inflammatory products that are derived from arachidonic acid. So we get leukotriene B4, we get prostaglandin E2. Okay, so this is fine. Once the crisis is over, we need to have this eicosanoid switch. So we need to move from a pro-inflammatory eicosanoid to an anti-inflammatory eicosanoid. So we move from the products from AA to the products from EPA. However, if we've got a dominant amount of arachidonic acid, AA, and we don't have enough EPA, then we don't produce enough anti-inflammatory products to actually kind of complete this whole sort of resolution step. So we kind of don't ever get to this stop signal. So we get this sort of bubbling over of, or bubbling under of sort of inflammatory products. And this is really quite well established now. So we need to up our EPA. Okay, so right. So low levels of omega-3 are common in insulin-resistant individuals. And it's not surprising that if we increase the omega-3 index by bypassing delta-5 desaturase, we can not only increase EPA, but we can actually lower the AA to EPA ratio. And we see improvements in both insulin sensitivity and the production of inflammatory end products. Okay, so when we look at the AA to EPA ratio, there's a significant correlation between AA to EPA ratio and insulin resistance, certainly in subjects with metabolic syndrome. It's also been suggested that balancing, and this is a quote taken from this paper, they suggest that balancing the AA to EPA ratio by lifestyle modification and using EPA-based sort of medicines, EPA supplements, could be useful in reducing the prevalence of metabolic syndrome and its associated comorbidities such as atherosclerosis and so on. So increase your EPA, reduce your AA to EPA ratio, and we can start to sort of make some amendments, really. Okay, right. So that's sort of metabolic syndrome. Let's have a quick look at diabetes. If we look at the association between fish consumption and the risk of developing diabetes, we actually see studies reporting that individuals with the highest intake of fish, as reflected by a higher omega-3 index, so in this case, this is a study from 2014, so I have to take this one with a pinch of salt as well, which I'll explain why. Okay, so individuals with in the highest quartile of serum long-chain omega-3 polyunsaturated fatty acids. So this is their omega-3 index, but I just want to sort of point out actually that they used serum fatty acids which aren't quite as accurate as looking at red blood cell membranes, but anyway, so they still had a 33% lower risk for the incidence of type 2 diabetes. So eating fish or increasing omega-3 has sort of benefits in sort of reducing diabetes risk. It's also worth pointing out actually that people who eat a lot of fish tend to, it's a bit of a general statement I know, but people who eat a lot of fish tend to have slightly better quality diets than people who don't eat fish, unless people aren't eating fish for sort of allergy or really just don't like fish. But people who include a lot of fish tend to sort of have slightly healthier diets. That's kind of well established as well. Okay, so so we know that fish consumption is associated with lower inflammatory marker levels among healthy adults, and it can actually also, or they can actually improve insulin sensitivity in both metabolic syndrome and type 2 diabetes. So another little study here, fish consumption is associated with lower inflammatory markers among healthy adults. So compared to non-fish consumers, people eating more than 300 grams, that's about 3 portions of fish a week, had on average about a third lower CRP, a third lower interleukin 6, and 21% lower TNF alpha. So these are some major TNF alpha, interleukin 6 are major sort of players in driving insulin resistance. Okay, so high fish consumption, right? Okay, not only reduces the risk of developing metabolic syndrome, but it's also associated with improved markers of cardiovascular health. So I've touched on this before, but this is just a sort of little study that I found as well that showed that people who had the highest fish intake less likely to have metabolic syndrome, but they also had lowest sort of levels of sort of lipid proteins, low blood pressure, lower blood pressure, lower cholesterol, lipids, and so on. Right, okay. So when we look at fatty acid levels in obese individuals, we see that saturated fats are saturated fatty acids are significantly higher and EPA levels significantly lower in obese subjects. And this is obese subjects both with and without insulin resistance. So we've sort of got a target for sort of intervention here. And this is compared to sort of non-obese individuals. With similar patterns are actually observed as well in people or individuals with metabolic syndrome. And this fatty acid pattern So high levels of saturated fat, low omega-3, low EPA. This fatty acid pattern appears to confer a really sort of higher risk of both developing diabetes and coronary heart disease, which isn't really kind of surprising, really, given the association with sort of cholesterol, lipids, and so on. Which actually leads me quite nicely into this slide. So this is a study published in 2014 looking at the effects of EPA treatment on epicardial, so this is the fat directly around the heart, and abdominal visceral adipose tissue volume, in patients with coronary artery disease. So quite a brief little summary here, but 30 patients over a 6-month period. They were either assigned to a control group, which was sort of conventional therapy, and an EPA group, which had the conventional therapy, and they also had 1.8 grams of EPA daily as well. And summary of the study: compared to control groups, treatment with EPA significantly reduced the AA to EPA ratio, but importantly, treatment with EPA significantly reduced fat accumulation around the heart and abdominal visceral adipose tissue. And there was also actually a non-significant reduction in abdominal subcutaneous adipose tissue as well. In regards to sort of inflammatory markers, they looked at CRP levels, and they were reduced, and they also showed significant reductions in triglyceride levels as well. So quite a nice little study there. Okay, so in addition to reducing sort of adipose tissue and reducing inflammatory markers, omega-3 fatty acids have also been shown to reduce the number of macrophage within the adipose tissue itself. So not only do they reduce the number of adipose tissue related macrophage, but they reduce the production of MCP1 as well, which is the sort of primary protein that attracts macrophage to the adipose tissue. So actually they also talk about if you can block or reduce MCP1 activity, this is itself a potential therapeutic target for reducing the risk of developing insulin resistance. So we're looking at things like the proteins that are sort of driving macrophage to the site. We're looking at reducing macrophage themselves. We're looking at the sort of genetic elements of reducing the activity of the genes that are involved in these processes. We're reducing the production and function of pro-inflammatory products, all kind of contributing through here. So in regards to sort of human intervention studies, they show great promise for a role of omega-3 in regulating obesity-driven insulin resistance. In vitro and animal studies contribute as well, because what they show is some of the sort of mechanisms behind the role of omega-3 in these sort of areas. And they, again, another kind of nice summary here as well. So omega-3 fatty acids, in brief, have been shown to induce a shift for M1 pro-inflammatory macrophage state to a more favorable M2 state. So we go back to our sort of housekeeping macrophage type phenotype, and vice versa. We also inhibit a number of signaling pathways that directly suppress adipose tissue inflammation. So we reduce levels of a number of pro-inflammatory products. So we're talking about CRP again, TNF-alpha, and so on. Omega-3 also activate PPAR, thereby decreasing the expression of molecules such as TNF-alpha that cause insulin resistance. Oh, I have to forgive me, my screen's just died. Can you just bear with me whilst I go and just get my... Right, I've just been told. I'm so sorry about that. It just goes to show that you should leave your laptop plugged in at all times. Okay, so I'll just refresh myself. I think so. So yes, we've just looked at some of these sort of animal studies and in vitro studies that really kind of help to support the role of omega-3, and there is a huge amount of supporting evidence that suggests that increasing omega-3 intake through either both, or sorry, not either both, through both oily fish and fish oil supplements can have a significant benefit, not only in reducing the risk of developing insulin resistance by modulating inflammation, but also as a potential treatment of the comorbidities related to insulin resistance itself. Right, okay, so this is where we lead into saying, well, how much omega-3 do I need to take? As practitioners, it's very difficult sometimes to kind of really establish how much we need to be giving to each individual client. And the simple answer is that it really does depend on the individual needs of the client. Two of the biggest factors that influence therapeutic outcomes related to omega-3 treatment are actually the baseline levels of omega-3s as determined by the omega-3 ratio, the omega-3 index, ignore that bit, and body weight. So for example, an 80 kilogram person is more likely to require more omega-3 to correct deficit than a 50 kilogram person. And these are factors that are rarely taken into account when we are prescribing. Okay, so this is really to just sort of tell you about our Optio 3 biomarker test. Now, some of you will, or some of you who have attended these webinars before will be familiar with it, so I'll go over it quite briefly. But the Optio 3 is a very unique blood spot fatty acid biomarker test, and we use it to gather information on an individual's omega-3 index primarily. So you get a full fatty acid screen, so 26 fatty acids. So we look for mono, poly, saturated. And if we know the omega-3 index at the start of your treatment, we can take your body weight into account in determining an optimal dose. So we use a model that was developed. And the Optio 3 is a test that therefore allows a bespoke dosing that is based on the client's base levels and their body weight. And as the omega-3 index rises, we see a corresponding decrease in the AA to EPA ratio. So the whole kind of purpose of this test really is to deliver a personalized plan that aims to achieve an omega-3 index of more than 8%. Now, this is based on a lot of the supportive research looking at omega-3 index as a risk factor for cardiovascular health. So we know that individuals who have an omega-3 index of 8% or more are at the sort of lower risk of developing sort of cardiovascular events, if you like. And an AA to EPA ratio of between 1.5 and 3 is a nice balance of pro to anti-inflammatory eicosanoids. So that's our Optio 3. And many of our practitioners are really sort of beginning to put it into their practice with very nice outcomes. So I've included this slide to just kind of give you a little bit of an idea of how it can be used. So this is an example, not of a patient as such, but it was a colleague within the office, and we gathered this data when we were developing the technique, and it's a good example really of how the Optio 3 can be a benefit. So this was a person who appeared physically healthy. They had no specific health conditions, but they did sort of report to sort of eating fish a couple of times a month, but there was no sort of like long-term pattern of omega-3 supplementation, and they were quite happily took this blood spot. And when the results came back, they came back really they came back indicating that they were at a high risk profile or an at-risk profile. And what do we mean by this? So if we look at the slide here, so that at baseline, their omega-3 index was 3.5. And if we look at our little sort of diagram here, as I've said, 8% is where we're kind of really wanting to be, higher if possible. Anything less than 4% puts you at a higher risk of developing cardiovascular disease. So really, we kind of want to be going this way. So at baseline levels, the omega-3 index was 3.5. At the beginning as well, they came back with an AA to EPA ratio of 8.5. So this is kind of in the suboptimal area. Again, we want to be sort of anywhere between 0 and 3, although between 3 and 7 is not too shabby either. Taking their body weight and their omega-3 index, we were able to work out that what they needed to do was take 1.5 grams of omega-3, and they took from me per restore, and they retested again after 4 months. And after 4 months, we found that the omega-3 index had risen to 5.98, and their AA to EPA ratio had dropped down to 3.54, which then draws them back up into the sort of desirable area, and then down from a suboptimal into an acceptable area. So they were quite happy. And they are carrying on taking the omega-3s, and they're going to have another retest in about 4 months' time to see how they're getting on. So it gives you a kind of idea of where people are in regards to how much omega-3 that they actually need. If their omega-3 index is particularly low, they may need more, or they certainly do need more. If their omega-3 index is much higher, they need less. So it offers a very sort of bespoke dosing guide. Okay, so if you use the Optio 3 in practice, you'll be able to support your clients quite considerably, because you'll be able to identify those individuals who may be at risk through sort of obesity-driven inflammation, insulin resistance, and so on. Also provides a good management tool for those who are suspected to be at risk of developing or are known to actually have metabolic syndrome or insulin resistance. So you kind of get a feel of how much inflammation is going on in the body. And it's also a good management tool for those comorbidities that are related to insulin resistance as well. And why do we take the DHA out? Well, part of the reason is that there is a huge amount of supporting evidence that shows us that EPA on its own, so pure EPA, plays a role in inflammation by displacing arachidonic acid, and DHA doesn't do it quite as effectively. So basically, there's nothing wrong with DHA, but EPA is primarily the anti-inflammatory omega-3 within fish oil. So it's becoming really rather well recognized, and everybody's sort of catching up with sort of scientific information. But so if we look, this is a couple of slides from, or this is a couple of diagrams from a recent paper by Flock, and they show that our pro-inflammatory mediators, so we've actually just missed out here. This is actually interleukin-6, this is TNF-alpha, and as our arachidonic acid content of our red blood cell rises, so do our inflammatory mediators. So if we reduce arachidonic acid content by increasing EPA, we reduce the AA to EPA ratio, we reduce inflammation, we reduce the risk of developing insulin resistance, and so on. So it's this really kind of nice domino effect of treatment, and if we can catch these conditions early, then we stand a much better chance of treating long term. And this is exactly what we kind of aim to do. So the purpose of this really is to manage our AA to EPA ratio stroke omega-3 index using EPA supplementation. And we know that individuals with high AA to EPA ratios and low omega-3 index are at the highest risk of developing insulin resistance, and therefore the comorbidities that are associated with insulin resistance. Levels of pro-inflammatory products in obese subjects directly correlate with the degree of glucose intolerance and insulin resistance. Treating with omega-3 improves pro-inflammatory profile patterns in both healthy and insulin-resistant individuals. Treating with omega-3 also lowers elevated cholesterol, lipids, and blood pressure, and these are factors themselves that are related to insulin resistance. Treatment, I have to say, is important, but intervention as prevention is really important for long-term health. And just a sort of final point is that EPA in E3s are also a useful addition to sort of weight loss regimes. So anybody who's trying to lose weight and includes omega-3 will lose more weight if they do than if they don't. Okay, so I think that's my final slide, and that's a nice picture of me taken in the garden last year. Right, I've just been past some questions. Okay, right. Okay, so I am just having a quick look at some of the questions here. Right. Let me just go back up. Right, if you just bear with me, I'm just having a look at some of the okay, so right, okay. Right, I'm going to. Right, okay, so. Right, I'm just scrolling through. Right, so does farmed salmon give the same benefit as wild fish? Well, certainly not in the sense of flavour, no. But actually, the fatty acid profiles between farmed fish and wild fish differ quite significantly. So, wild fish is significantly better in terms of sort of the protein quality, the antioxidants that are in there, the vitamins, minerals, and the omega-3 composition as well. So wild fish, it should be sort of your first port of call. So that's that. When we look at questions, surely DHA plays a role in inflammation resolution too? Yes, you're perfectly correct. It does too, but it plays quite a much lower, if you like. EPA has been shown quite significantly to be more anti-inflammatory than DHA, and there are some conditions that have shown that DHA does have the potential to actually increase inflammation in some states. We're actually very honoured to be participating or sort of working alongside Hull University, and we are participating in the seafood trial, which is it's a colorectal cancer polyp prevention trial, and they're using our pure EPA product as an intervention tool. Primarily because we are pure EPA, and there is evidence that DHA can sort of increase inflammation, certainly within the sort of colon environment. So DHA does have a role in inflammation, but there are some cases where DHA may increase inflammation. So taking the DHA out certainly isn't going to be any harm, and it improves the anti-inflammatory benefits attributed to EPA. EPA directly compete with arachidonic acid, whereas DHA doesn't quite so much. So pure EPA is the top product when it comes to sort of reducing inflammation. And I think that really kind of answers Mina Wood's question as well. Right, okay. EPA, DHA levels of tinned fish, sardines, salmon compared to fresh fillets. Actually, I think, if you're going to sort of look at sort of consuming fish, then tinned fish is absolutely fine. Sardines and salmon, yes. The only thing that I would say is, like, be careful of tuna, because the fatty acids are actually removed during the canning process. So the amount of omega-3 within tinned tuna is not quite what it should be. People happily eat their tuna thinking they're getting their omega-3 quota when they're actually may not be. So if you're going to go for tinned fish, certainly sardines and salmon are probably going to be the best ones. Right, just having a look at what are the effects of omega-3s from vegetarian sources in comparison to fish oils. Right, okay, that's quite an easy one to answer as well. If we go back to our right, so our omega-3 fatty acid. So we start at the top. Our parent fatty acid, ALA, converts through delta-6 desaturase to stearidonic acid, to ETA, to EPA. Flaxseed oil, for example, which is our sort of common choice of omega-3 fatty acid supplement, is predominantly ALA. So our fatty acid has to then go through several steps before it actually becomes EPA and sort of physiologically active, if you like. So the amount of ALA that you need to consume to get the same kind of level, and we're talking about sort of grams of EPA as therapeutic. So, for example, if we're treating depression, you need about 1 gram, schizophrenia 2 grams. If you need to lower elevated triglycerides and cholesterol, you need anywhere between 2 and 4 grams of EPA. Considering that only about 8% of ALA converts through to EPA, it kind of implies that plant-sourced omega-3s really aren't going to offer the same kind of therapeutic value. We do actually have a product that caters for vegetarians, and it's called Echium seed oil. And the reason that we produce Echium seed oil is that it provides a vegetarian alternative to flaxseed oil. It's got a very unique omega-3 composition in that it's very high in ALA, but it's also a rich source of stearidonic acid. The relevance of this is that it bypasses delta-6 desaturase, and stearidonic acid converts through to EPA a lot more efficiently. Echium seed oil actually also contains GLA as well, which is known to be quite beneficial as well. So in regards to vegetarian sources, certainly go for Echium seed oil over flaxseed oil, for example. Right, I think have I got Sophie with me now?
I think so. Can you hear me?
Yeah, I can. Hello, Sophie.
Hello, everyone. How are you? I hope you've all enjoyed Nina's webinar. I certainly have. I've been hiding in the background here, so I'm just going to jump in and give Nina a hand with a few questions that sort of I've been researching away in the background as they popped up, because it's not necessarily something that we came across as part of our research in writing this webinar. But with regards to your question, Iris, right at the beginning of the webinar, you mentioned how does hyperinsulinemia differ from normal insulin resistance? Well, actually, that's sort of a contradictory question in a way, because hyperinsulinemia is what happens when we are insulin resistant. So hyperinsulinemia is basically just the medical term used to say that we've got higher insulin in our blood in response to glucose than would be expected. So people with metabolic syndrome, people with kind of early, would definitely have hyperinsulinemia and also obviously be showing symptoms of insulin resistance. That's not to say that they would have been fully diagnosed with insulin resistance, but they would have high levels of insulin. So it's sort of the same thing, if that makes sense. I hope everyone agrees with that, and that there's nothing I'm missing there. But essentially, high insulin is as a result of your body and your muscles and your cells not fully recognizing insulin in response to glucose, and the pancreas pumping out more insulin than can actually be utilized, that can be effective relative to the amount of glucose. So fingers crossed that answers your question. I'm just going to quickly scroll back through and check that there's nothing else that Nina. So Golda, you asked a question specifically about omega-3 supplements relating to hormone disruption. It's not something myself nor Dr. Bailey, as far as I'm aware, has come across. It would be really interesting actually, and if you fill in the questionnaire at the end of the webinar when you log out, if you could leave your phone number, what we'll do is we'll do a little bit of investigating for you, and I'll give you a call and we can just chat through that in a bit more detail. Same with anybody. If you've got questions, if you want to know more, if you've got queries, please fill in the survey, give us your phone number. Sorry, Dr. Bailey very noisily picking up her microphone there.
Oh, sorry.
So if you do have any specific questions, anything you need to know that we're not able to cover during the webinar, fill in the form, give us your phone number, find a random box that you can fill in a question, and we will give you a call. Let us know that you want to speak to one of us, and we'll make it a priority to give you a call and just chat through anything. As I say, if we don't know the answer now, it's because we haven't